here are members of the Stroke for Thoracic Endovascular Procedures team, or elements of it. This term started a little while ago, Fiona. Explain why we did it, the study, and then we can discuss some of the findings.
Mm-hmm. Yeah, the study started because we wanted to get more experience on procedures done in the region of the aortic arch, endovascular procedures. And these are procedures not done at many centers. And to get a better overview, what are the results of the current done procedures, we needed to find a way to increase the numbers we can evaluate. So we tried to establish the STEP platform with the high volume centers collaborating on the STEP study, and also including those collaborators who were nominated by the manufacturers who produce the devices of interest to be high volume or higher volume performers of these procedures.
Why did we go to the manufacturers? Because our critics would say that we were in the control of the manufacturers. What was the reason for it?
Yeah, of course, that's also a point we were thinking about in the beginning, but for us it was important that we include all companies who produce devices that are used in the aortic arch, so that we have an equal contribution of each company and also no funding of the company. But of course we also needed the companies to tell us who are the operators they trust.
And in your concept, do we feed back information to the manufacturers which could be of benefit?
We aim at sharing all the results we get with everybody included and involved in the study. It's including, of course, the manufacturers too.
So, Tilo, today we listened to new data, and we had 37, of which the majority were from Hamburg and some from Paris, and one from the Mayo Clinic. What was your main finding that sticks in your mind from these 37?
The analysis which Fiona has done so far is a preliminary one, and it mainly shows that STEP can provide in relatively short time a significant number of cases in relevant landing zones with a risk for stroke. What we could already show today is that we could repeat the findings of previous studies on a larger scale, that silent brain infarctions happen in a percentage between 60 and 80% of TIVA cases. And what we will analyze more thoroughly in the future when we have collected more data is look at risk factors of stroke. What was also interesting in the findings was that the frequency of silent lesions decreases with the distance from the aortic valve.
So, Tilo, particularly in zone 3, the conclusion must be that there's room for technical improvement to reduce embolization if any of that is from solid material, scraping along the sides of atherosclerotic aorta. Would you think that that is relevant, or do you think that's unimportant?
No, I think that is something that is worth exploring as we see more and more cerebral protection devices, filters or deflectors getting closer to market. We should learn whether it makes sense to apply those protection devices to carotids and subclavian arteries. What is difficult here is that placement and retrieval of those devices also may be causes of stroke. They may release gas bubbles as well, but that should be studied in the future and is an important part.
So, Heinz, where is open surgery still the winner?
Well, we have problems if we are dealing with the arch, no matter if it's acute or chronic dissection or aneurysms. And I just checked our data from our EVITA Open International Registry. It was updated just 2 months ago with more than 1,100 patients followed up to 10 years. we have a rate of 6% stroke in all those different 3 types of disease. So we have to
in all
cope
3
with that.
pathologies.
In all 3 pathologies.
Yeah.
So although I thought that we are continuously perfusing the brain via the right axillary artery, direct cannulation of the left carotid, and also cannulation of the left subclavian artery, we have those problems. So air shouldn't be the bad guy. Probably it's solid emboli. And there's also a small proportion of hemodynamic strokes, no doubt.
Try to explain in open how air on the one hand or hemodynamic on the other hand or particular embolization can occur in open.
Well, we did studies in coronary bypass surgery and in valve surgery, open versus TAVI, and with the DW MRI testing, we have seen the same phenomenon as you see now, that in the TAVIs, 80% of the patients had lesions. In the open valvular, 60%, and in the coronaries, where we don't open up the heart, 50%. There was no correlation to the neurocognitive testing we have done extensively, but there are lesions. Interestingly, after 3 months, most of the lesions are gone.
What do all of you think about the contributions of transcranial Doppler or psychological testing, psychometric testing? Should we be listening to other methodologies for those centers that want to do those things? We discussed that at the beginning. Is that realistic to do this?
I think transcranial Doppler is a very good tool to quantify how many hits occur in which part of the procedure. But I think we really should listen carefully to the neurologists that tell us that it's difficult to distinguish the cause of the hit, if it's gases or if it's like solid emboli.
Well, Fiona, that's exactly what all neurologists around me have said. And I was a big user of transcranial Doppler and altered my carotid technique absolutely based on that. But I had an outstanding vascular technology who could give me a signal of the middle cerebral artery. I altered my flushing technique after carotid procedures, and so that I used to think that I was allowing the blood flow to go to the external carotid so that it wouldn't hit the brain by opening the internal. And to my horror and surprise, I found that there were hits on the middle cerebral artery, surprisingly many, when I perfused through the external carotid artery. And that altered my technique to back bleed from the external carotid artery much more before then they let air and anything out, before I then restored blood into the external carotid, and that got rid of the hits. So transcranial Doppler can be a mark of how to improve your surgical technique. And then you can translate that also to the common and the internal to get rid of the air. So in open carotid procedures, transcranial Doppler taught me how to get better and better and better results, and that correlated with lower and lower and lower stroke problems. As surgeons, we always want to try to add together what it is we're finding and explain it, but it's not always easy, is it? At least if it's a measure of how to do the job better, we can be pleased with that. I'll ask all of you in the last question, what have we learned from STEP, and what should we do next? Fiona?
I think we have learned that we have to do a lot more to understand what we can make better and find solutions for it especially.
What in particular do you think needs to be done?
It needs to be standardized among surgeons, how you can perform best practice for the procedures, and I think there has to be a much more communication on different techniques that might have better outcomes, so that all the benefits that might be known at different centers can be combined.
That's the idea of STEP. Tilo?
Yes, I learned that cerebral damage is a significant issue in thoracic endografting, and that there are many motivated physicians and researchers who aim to work together to reduce that damage.
That's very encouraging, isn't it? Heinz, what do you say to us?
Well, I think you're on a good way, but if to go into more detail, you should maybe add neurocognitive testing, as we have done in the past with our coronary patients. We did a battery of, I think, 14 testings. Mm-hmm. And there was 80% of the patients had some deterioration post-operatively, but after 3 months, only 20% stayed with deterioration. So I don't know if it can be extrapolated, but theoretically you should add this kind of testings, and in addition maybe a follow-up MRI after 3 months.
Should we be approaching the 5 manufacturers to collaborate with a STEP study to fund DW MRI after the procedures we are, to expand the number able to do it if they're using their devices, and also at 3 months to see if the lesions have disappeared, and also those centers who would like to do cognitive function, that it should be done. Should we approach them, or should we apply for funds which are completely independent, or should we carry on as we are doing? Fiona, what's your view?
That's a tough question for me to answer right now, because there has to be lots of discussion to be done in advance with those people who are involved in that decision. And I think we cannot tell from where we are now what is the best way to do.
Tilo?
In an ideal world, we should seek independent funds, but after calculating costs of those studies, we should reconsider whether we can get the necessary amount that way, or whether we need help of manufacturers. But if we do, this should be a very well organized way of collecting that money that is independent from each.
They're designed independently of them, and if they join the study that is mapped out by the STEP investigators. Heinz, what do you think?
Well, either all manufacturers at equal parts, or even better, public funding.
Thank you. Thank you all very much.